Good evening, everyone, and thank you for coming out. My name is Marlene Meyers. I'm a medical oncologist, and particularly a breast medical oncologist. And I just also want to say to Erin that you are truly amazing. When I was 16, there was no way I would have been standing up here. So imagine the things you'll do by the time you're my age, 24. It's not funny, that was not a joke. But I'm going to limit my remarks this evening to understanding your risk of developing a second cancer. So how many of you either have or know someone who has one cancer and then you think everything is okay and then you find out they have another cancer? So it actually is a pretty common thing, but in terms of cancers, it actually is quite rare. And the good news is the reason that it happens is because we've done so well with treating cancer. People are living longer, they're surviving, and sadly one price to pay for survival is the risk of getting another cancer. But the news actually is quite good. We have good ways to diagnose it, and what we're going to talk about this evening is understanding why that happens so you can do whatever is possible to prevent it. Sure. Is this better? Okay. So for the first audience response question, let's talk about what is a second primary. Is it a recurrence of cancer in the same place? Is it a metastatic lesion, or is it the development of a new type of cancer in someone with a history of cancer? Do I have to click it again? You can click on your little thing, whatever answer it is. If I click it again, it'll go right. Okay. Correct. So the answer is C. What a second primary is really has nothing to do with the first primary, except that the first primary may increase the risk of a second one for various reasons that we're going to talk about. But a second primary cancer is the development of a brand new type of cancer. So it's not a cancer that comes back elsewhere in the body. It's not a cancer which is metastatic. It's a brand new cancer. So it doesn't really seem fair that you should have one cancer and then get another cancer. But it does happen. The good news, though, it is a relatively rare event. And some people, when they get the second cancer, start to think that they're sort of cancer knows where to find them, that they know where they live and they're out to get them. But it's actually not at all like that. What it is it has to do with lots of different things that increase your risk of a second cancer. And I mentioned some of them can actually be effectively taken care of. So the next question is, which of the following statements are true about second cancers? So all survivors have the same risk of second cancers. There's a greater risk of second cancer being the same type as the first. Survivors have a 40% risk of second cancer, and survivors have a 15% risk of a second cancer. So it's actually pretty split. This is a tough question, but the correct answer is C. So it refers to B and D. There actually is a greater chance of you having a cancer that's the same type as the first. So one breast cancer having a contralateral breast cancer, one melanoma having another melanoma, than there is of getting a brand new cancer. And the actual chance of this happening is only about 15%. So what are some of the risk factors for second cancers? And we'll go through each one briefly, but the first is aging, family history genetics, foregoing routine screening, field effect, prior cancer treatment, meaning the type of cancer that you had and the treatment that's required, and lifestyle. So let's talk about aging. Cancer is basically a disease of aging. So the older you are, the greater the risk of cancer. So for example, many men between the ages of 80 and 90 do have prostate cancer. So if they have had, let's say, lung cancer at the age of 60, and develop prostate cancer at the age of 85, this is a second cancer, but it really is not a risk factor for that cancer. It's really just that they have an increased risk because of the aging process. People who live longer, survivors who live longer, have an increased risk of cancer. And the risk of Hodgkin's disease, there's about a 20% risk in 20 years in adults who have Hodgkin's disease that they will get another cancer. And skin cancer is also extremely common, aging related, sun related, so the older you are, the more you're outside with the UV lights, the greater the risk that you'll get skin cancer. So those are all second cancers, skin cancer, prostate cancer, but they're all quite common, so even though it is considered a second cancer, it's not typically what we get nervous about. Family history and genetics is very important. It's very, very important to know your family history. Many of you probably know about the BRCA1 and BRCA2 genes, so having that gene significantly increases your risk if you've had breast cancer of getting some of the other types such as ovarian, pancreas, prostate, melanoma, among others. So that's an important thing to know, because when you're seeing your doctor, when you're thinking about symptoms, when you're going for screening, those are all really crucial. Lynch syndrome increases the risk of colon and ovarian cancer, and a gene that was recently in the news that was described is the PALB2 gene, which increases the risk of breast cancer. And this is particularly important if you know families or you're in a family that has a lot of breast cancer, but you've been tested for BRCA1 and 2, and it turns out you're negative. So in terms of genetics, another important thing to remember is we know what we know. So are there other genes out there, other familial genes? The overwhelming likelihood is yes, it's just we don't know about them yet. Probably one of the most important things is screening for second cancers, and screening without tunnel vision, as I call it. Believe it or not, cancer survivors are the worst offenders of not getting screened. So the person who had breast cancer, you almost have to twist her arm together to do a colonoscopy. Nobody likes to get screening, but it's particular among survivors that it's very difficult to get them to be screened. This includes, so some screening we know is absolutely important, and that includes colonoscopy, pap smears at a certain age, skin screening, mammography. That doesn't mean that list is complete, but we know that those are sort of the basics for screening. Other screening is somewhat controversial. PSAs for prostate cancer in men. How important are they? What age should you do them? When should you do them? How should you react? And MRIs in people who have had breast cancer. Screening is an individual and is individually done and part of a cancer care plan. So one thing that we do at the Perlmutter Cancer Center is when people finish their treatment, we go over a care plan. Going forward, how often should you see your doctor? How often should you be screened? What do you do going forward so that if you can't prevent a cancer, at least you can pick it up early? And a really important thing is not to have tunnel vision. And basically what that means is if you've had colon cancer and you're going for your routine colonoscopy, it doesn't mean that you should skip your mammogram. It doesn't mean that you should skip your GYN visit. Survivors are surviving, so it's important that you take care of health in your entire body. One very important concept is field effect, which are molecular abnormalities in tissues that appear normal. It's a little difficult to see, but the top picture is out of a colon with colon cancer, which is sliced open. But around the area, you can also see some color abnormalities, you see some polyps. So that entire area has molecular changes where if you look under the microscope, while the cancer is pretty clear, it's sort of right in the middle of the screen, the other areas are maybe not so clear, but they all have premalignant changes. And in people who have colon cancer, they may have these changes elsewhere in the gastrointestinal tract. People who have breast cancer, they may have changes in the breast, the same breast or the contralateral breast, which can be even a couple of inches away from the primary tumor. And that's why, for those of you who have had breast cancer, your surgeon may have discussed with you that she or he had to get good margins, and that's the reason for it, not just to take out the primary tumor, but to make sure that if there are any lesions away from that, that's removed as well. The field effect is common in several, not in all cancers, but in several types of cancer. So the tumor types where we know there is a potential field effect are head and neck, colon, prostate, breast, lung, esophagus, stomach, and skin. And those are where the cells of certain origins are very similar to one another. So, for example, the cells that line the lining of the esophagus are very similar to cells that line the lining of head and neck. So it's very common where you see malignant or premalignant changes in one area, you may see them in another. The hypothesis is that there are stepwise genetic alterations. Cancer doesn't just happen, but it's a sequence of events, and that there is something called epigenetics that downregulates suppressor genes. What that means basically is you have genes in your body where if a cell becomes abnormal, those genes kill or shut off the cell. What epigenetics means is that those genes don't function so well. So if you have an abnormal cell, nothing tells it to stop growing. What we don't know about field effect is this a primary or a secondary event? In other words, are the abnormalities around the tumor part of the same process, or are the abnormalities reacting to the fact that a tumor is there? So that's so far unexplained. But this does give us good opportunities for chemoprevention and for enhanced surveillance. So if we know somebody has squamous cell cancer of the head and neck area, we know that they're at risk, so they have enhanced surveillance by an ear, nose, and throat person to make sure there aren't any other lesions. If you know or you have had a marker for the development of breast cancer, such as atypical hyperplasia, that's in a sense a field effect, and we can use drugs like tamoxifen to try to reverse those changes. Prior cancer treatment is extremely important in terms of risk of future treatment, particularly radiation therapy. And radiation therapy, we actually learned about the effects of that from survivors of the atom bomb, as well as from people who work in high radiation exposure fields. And we know that the risk of radiation goes up in people who have had more intense radiation to a particular field, a longer dose of radiation, and more toxicity to the bone marrow. Chemotherapy as well, depending on the drug that you've gotten, can increase the risk of cancer. A particularly common drug for that is the drug Cytoxan, which is an alkylating agent. This is a drug that's common in treatment for breast cancer, for some lymphomas as well. The other drugs that can cause second cancers are drugs like cisplatin and topoisomerase inhibitors. The alkylating agents, however, the ones that tend to have the worst outcome, they typically will cause an increased risk of acute myelocytic leukemia, and those leukemias are particularly difficult to treat. But the good news is that the benefits of treatment of the primary cancer with these drugs far, far outweighs the risk. And in fact, the risk of developing a leukemia with chemotherapy is about 4.4%, so it's quite low. And other drugs such as tamoxifen may increase your risk of uterine cancer. So sometimes drugs we use to fight the cancer actually can cause other cancers. But the reason that we use it, and the most important concept, is that these drugs have improved survival. And the worst cancer you have is the one you have, and that's the one that needs to be treated. So what can you do to prevent another cancer or to pick up another cancer early? You can know your treatment history. It's really important to be aware of drugs that may cause leukemia, that may cause other side effects. Develop a survivorship care plan with your doctor so you know when the screening is, what the screening is. Schedule regular screenings. No one likes a colonoscopy. I assure you I do not. I've been doing this for 35 years and I've never had a patient beg me for a colonoscopy, ever, ever. But aside from the perk of losing a couple of pounds when you have it, it is a crucial test, because if there is one test that can truly prevent a cancer, it is colonoscopy. Know your family history. If you have a strong family history of breast cancer, of colon cancer, make sure you report that to your doctor. And healthy lifestyle is crucial because we are learning more and more every day that lifestyle change can make a difference in second cancers. So when we talk about lifestyle, what are we talking about? Basically, all the things that you want to ignore, which are things like diet, exercise, smoking, alcohol, and sun exposure. You have to make really good choices. Diet is crucial. We know, particularly with breast cancer, that a diet that's healthy, that's low in fat, and a good body mass index may in fact lower the risk of recurrence and may lower your chance of getting another cancer. Smoking, goes without saying, is not a good thing. Alcohol can increase your risk of certain cancers, especially the upper GI tract, and sun exposure increases the risk of melanoma and of non-melanoma skin cancers. So which of the following is true about smoking? A smoker only has a risk of a second lung cancer. I already have lung cancer, so there's no point in quitting now. A chronic sore throat after radiation for lung cancer needs to be investigated. My lung cancer is cured and I quit. No worries. Most of you got it right, and that's number C. A chronic sore throat after radiation for lung cancer needs to be investigated for several reasons. Number one, the lining of the lung is a very similar lining to other organs in the throat and the head and neck area. In addition to that, someone who's had radiation, that person may have an increased risk of another primary, particularly if they've had chemotherapy with radiation. So all of that does need to be investigated. So we all know, goes without saying again, that smoking is bad for you, but important things, very often we'll hear, you know what, it doesn't matter, it doesn't make a difference now. If I quit, if I don't quit, I already got lung cancer. Well, it turns out that in fact it does make a difference. And in people who have smoked or actively smoking before their diagnosis of lung cancer, those people have automatically a higher risk of a second primary cancer related to smoking. So when you quit, quitting any time is helpful. Related cancers are cancers from the lung, from the bladder, the kidney, head and neck area. There's a 5-fold increase of developing a second smoking-associated cancer. Current smoking increases mortality, so even if you've been cured of your first cancer, if you continue to smoke, your mortality is still increased. And former and light smokers also had an increased risk. So even if you're a former smoker, it's much better than being a current smoker, but you can't stop getting screened. Breast cancer and secondary cancers are extremely important. Breast cancer actually makes up the majority of survivors, and about 25% of all survivors have had breast cancer. There is about a 22% relative increased risk of a secondary non-breast cancer within 10 years. Chemotherapy, as we spoke about, is linked to AML, which is acute leukemia, and MDS, which is myelodysplastic syndrome. The dose and the regimen has something to do with that. Growth factors it's a little bit unclear, but drugs that elevate your blood cell count may have something to do with that. However, as I mentioned before, compared to your risk from untreated breast cancer, there is a very low absolute risk. In women or men who get radiation with chemotherapy for breast cancer, there's an increased risk of lung and angiosarcomas, which are blood vessel tumors. However, the most common second cancer is breast cancer. So when you're getting screened, if you've had a mastectomy, if you've had a lumpectomy, don't forego breast cancer screening. So the most important things are you do have control over second primaries. Well, some things just happen. You can prevent some of those things from happening or mitigate how badly those things happen. And a very important one, as we mentioned, was lifestyle changes, diet, exercise, avoid sun exposure during peak hours, stop smoking, alcohol within moderation. Screening, for those of you who have never seen or had colonoscopy, that's what it looks like. So if any of you in the room have not seen it, that's bad. That's what it looks like. Colonoscopy is important, MRIs, mammograms, pap smears, And chemoprevention, that's a bottle of tamoxifen, which is used to reduce the risk of breast cancer and can reduce the risk by as much as 50%. So there is lots of optimism, but still some reasons for concern. Second cancers occur because of increased life expectancy, and that's good. There's less use of carcinogenic regimens, so because we know some drugs can increase the risk of cancer, we tend to shy away from them and use other options when possible. IMRT, which is a newer form of radiation, which is intensity modulated radiation therapy, that's been around since 2003. So we don't have the same data with this as regular radiation. If you look at radiation-induced cancers, they may not occur before 5 to 9 years or even past then. So the data we have on IMRT is not quite as robust, and the concern is because it's somewhat more intense and focal, that may actually increase the risk. The overall numbers of second primaries are very low. The benefit of treatment definitely outweighs the risks, and some risks can be modified, but some risks cannot. And screening can certainly be better. And as we learn more about field effect and we learn about what cancers are related to others and how they're related, our screening will get better as well. So we need more understanding of risk versus benefit. An oncologist who's meeting with you will always tell you about the risk versus benefit of a treatment. It's important to ask those questions. But new treatments bring unknown long-term effects, so it's uncertain sometimes what the best screening is. We have lots of new drugs, things that modulate certain growth factors, things called CDK inhibitors, EGFR inhibitors. So these are all drugs that are relatively new, so we don't really know what happens 10, 15, 20 years after using them. But there is hope on the horizon. The great news is we're curing more and more cancers. We're not doing as well as Dr. Gardner and her group is doing, but we are doing pretty well. And as you mentioned, there are many, many more adult cancers. As an example, breast cancer alone, there's about 240,000 new breast cancers every year. So it is a much more common disease, and that's why we do see more in the way of second primaries. But our treatment has gotten better, life expectancy has gotten better, and hopefully our approach will get better as well. Thank you.